In this lecture, we are going to discuss exposure of important blood vessels, including the ascending aorta and its branches, the descending thoracic aorta, abdominal aorta and its branches, the celiac artery, the superior mesenteric and renal arteries, the hepatic artery, splenic artery and splenic vein, the inferior vena cava, renal veins, portal vein, and the internal iliac artery. And as I told you last week, exposure of blood vessels is very important for the vascular surgeon. For every vessel in the body, there might be one or more than one approach or exposure. We should know the details of such exposures so that when we need them, we can apply them to our patient immediately, saving the time and saving the life of the patient. Anatomical knowledge is very important, as well as safe dissection. So if we start with the exposure of the ascending aorta, the usual incision used for this vessel, for exposure of this vessel, is the median sternotomy. Although various incisions are made to expose the ascending aorta and its branches in the neck, the most commonly used one is median sternotomy. And as you know, median sternotomy is a vertical incision extending from the suprasternal notch down to the xiphisternum, and the bone, the sternum, should be divided. Usually, the bone is divided by an electrical saw. However, sometimes if we don't have an electrical saw, we can use another simple method. We do a blunt and sharp dissection in the suprasternal notch to create a tunnel behind the sternum superiorly, and similarly we do a dissection beneath the xiphoid process to create a space behind the xiphoid process, and then we introduce a long straight artery forceps. The tip of the forceps will grasp a gigli saw, and the gigli saw will be passed immediately below the sternum, and we lower the table a bit and we ask the anesthesiologist to stop ventilation for a while, and then we divide the sternum using the gigli saw. In both techniques, whether an electrical saw is used or the gigli saw is used, there is a possibility of opening of the pleura, and in that case we have to put a chest tube at the end of the operation. The closure of the sternum should be done by stainless steel wires, and the two halves of the sternum should be approximated very closely so that we don't have a complication of median sternotomy later on. Please, if you have any question or comment, I prefer to keep them at the end of the presentation. Okay? Do you agree with me?
Yeah, it's okay, sir.
Yes.
Okay.
Yes, we hear you.
Well, after the sternum has been divided and a retractor is placed, the important structures in the anterior mediastinum will be visible, like the thymus gland, concealing the ascending aorta and the major veins. And as you can see, the veins lie in front of the aorta. We have the left innominate vein and the right innominate vein. They join together to form the superior vena cava with some dissection, and we can encircle the left innominate vein by a tape or by a sling, and we can displace the left innominate vein a bit inferiorly so that we can see the ascending aorta and the major branches, the brachiocephalic trunk on the right side, and the left cava and carotid to the left side. Well, sometimes we need to have a better exposure of the vessels in the neck, the branches of the ascending aorta, and in that case we may add a transverse extension to the vertical extension or to the vertical incision. The incision will be a T-shaped incision, and after putting a retractor and division of some muscles, the sternocleidomastoid muscle and the anterior scalene muscle, will have a very good exposure of the branches, including the left subclavian artery. And with such an exposure, the surgeon may be able to do many operations, even placement of grafts between the branches of the aorta and the ascending aorta if needed, and so on. So this is an ample exposure of this area, and it's simple to be performed, and also simple to be closed. The descending thoracic aorta is a big vessel, and many times we need to explore or to expose the descending thoracic aorta for many indications, elective and emergency situations. And for that exposure, we need a lateral thoracotomy. The thoracotomy can be made in the 5th intercostal space or in the 8th intercostal space, depending on which part of the descending thoracic aorta to be isolated or to be explored. The 5th intercostal space is used for the upper descending thoracic aorta, while the 8th intercostal space is used for the lower descending thoracic aorta. Rib removal or rib resection is optional, okay? And when we open or we enter the thoracic cavity, the lung is displaced anteriorly, and this will expose the descending thoracic aorta in a good way. I don't know whether anybody is trying to joining us, or all of you is with me. Okay. Very good. Yes. Now, for exposure of the lower thoracic and upper abdominal aorta, we need a different incision that is called left thoraco-abdominal incision, or the thoraco-phrenolaparotomy incision. Thoraco-phrenolaparotomy incision is composed of two incisions, a midline vertical incision in the abdomen, which is extended into a lateral thoracotomy incision, either at the level of the 5th rib or at the level of the 7th rib, depending on which segment of the descending thoracic aorta to be isolated. So this incision, the thoraco-abdominal incision, enables us to enter two body cavities, the thoracic cavity and the abdominal cavity. After dividing the abdominal muscles, the rectus abdominis muscle, we have to divide the costal margin, the cartilaginous costal margin, and that will allow us to, and later on you have to divide the diaphragm as well. So this incision is characterized by providing the surgeon with a very good exposure of both the thoracic cavity as well as the upper abdomen, and can be used not only for exposure of the aorta, it can be used for other operations on the GI tract, on the esophagus, the upper stomach, for tumors, for splenectomy, etc. So there are many indications for this incision. And in vascular surgery, it can be used to expose the lower thoracic and upper abdominal aorta. And the main disadvantage of this incision is the closure of the costal margin at the end of the operation, and of course the interference with the function of the diaphragm. So okay, as you can see here, the diaphragm should be divided, and there are two methods of opening of the diaphragm: either a transverse incision near the costal attachment of the diaphragm, which is away from the branches of the phrenic nerve, but unfortunately it provides less optimum exposure, or a vertical or radial incision from the periphery of the diaphragm towards the hiatus, the esophageal hiatus. This incision definitely will injure the branches of the phrenic nerve, and therefore at the end of the procedure we end with phrenic nerve paralysis and elevation of the diaphragm on the side of the operation, but it gives us a very good exposure. So if we look at this picture, now the left thoraco-abdominal incision has been done. The diaphragm has been incised by the radial incision, and we can see the lower descending thoracic aorta, and we can see the upper abdominal contents like the liver, the spleen. Okay, yes. So in order to expose the upper abdominal aorta in this incision, what we need actually is just to displace the upper abdominal organs to the right side. So here you can see that the liver, the spleen, the colon are displaced to the right side, and the upper abdominal aorta became visible with its major branches, the celiac axis, the superior mesenteric artery, the left renal artery, and you can see also the left renal vein crossing in front of the abdominal aorta. So this is a left thoraco-abdominal approach, or called thoraco-phrenolaparotomy. It gives us an ample exposure of the upper abdominal aorta, and it is considered a transperitoneal approach because the peritoneum is open. So it is a transperitoneal approach, as if we have done a laparotomy plus thoracotomy. Now, sometimes we need to expose a blood vessel in the abdomen, the aorta or its branches, without doing a thoracotomy. Not necessarily we do a thoracotomy. In that case, we are going to do a laparotomy. And the abdomen can be entered by doing a variety of incisions, either a transverse incision like in A, in the upper, middle, or lower abdomen, or a vertical incision like in B, or an oblique incision like in C. Okay, whatever the type of the abdominal incision, the procedure inside the abdomen is the same. Okay. Yes. Now, after we enter the abdomen and we want to expose the abdominal aorta, the infrarenal abdominal aorta, it can be exposed by displacing the bowel to the right side of the abdomen and doing an incision in the peritoneum lateral to the DJ flexure, the duodenal flexure. And this will expose the infrarenal segment of the abdominal aorta. And I'm sure you have seen this exposure in operations on the aorta for the sake of aortic aneurysm or for the sake of aortic occlusive disease. Okay, so this is the exposure of the abdominal aorta. The bowel is displaced to the right side and an incision is done in the peritoneum lateral to the DJ flexure. Now, apart from the transperitoneal exposure of the abdominal aorta, we have also a different approach called the retroperitoneal exposure of the aorta. In that case, the patient is placed in a lateral or semilateral position, just like for surgery on the kidney or for surgery for lumbar sympathectomy, and an incision is made in the flank or in the loin. And the muscles of the abdominal wall are either divided or splitted, and then the peritoneum with its contents is displaced to the right side. And this will expose the abdominal aorta from the level of the renal vein downwards, and the infrarenal abdominal aorta. And many surgeons prefer this approach for many reasons. It can be used for surgery on the abdominal aortic aneurysm or for other indications. So this is a retroperitoneal exposure of the infrarenal IVC, infrarenal abdominal aorta, sorry, infrarenal abdominal aorta. Well, you remember the main branches of the abdominal aorta, the celiac axis, the mesenteric artery, the arteries, and remember the previous slide number 9, in veraco, laparotomy. Now, if we do just laparotomy and we want to expose the celiac axis, it can be approached or isolated in this technique. Number one, we have to incise the lesser sac, the peritoneal fold between the stomach and the liver. The lesser omentum or the lesser sac should be opened. After that, the abdominal aorta can be felt in the depth of the wound. With downward displacement of the stomach, we can see the two crura of the diaphragm, and by dividing these two crura and displacing the stomach inferiorly, we can isolate the celiac axis or the celiac artery. And if you look here, this is the hepatic artery. So if we want to expose the hepatic artery, we do the same steps. We open the lesser omentum and we displace the stomach downwards, and we see the hepatic artery arising from the celiac trunk. And in this picture, you see that the two crura of the diaphragm haven't been divided. So it depends on the situation. You may divide the core of diaphragm or not, depending on your goal. For example, in trauma, and if you are bleeding and you want to put a vascular clamp on the upper abdominal aorta, division of the core is important so that you can put a clamp on this segment of the aorta. So that is exposure of the hepatic artery. Well, now near the hepatic artery, we have another important vessel called the portal vein. The portal vein is located in the free edge of the porta hepatis and can be exposed by isolation of the hepatic artery and the bile duct and displacement of these two structures medially so that the portal vein will be seen. And you remember the portal vein needs to be isolated for the sake of some operations like the porto cable shunt. Yes. Now, if we go back to the superior mesenteric artery, which is one of the branches of the upper abdominal aorta, how it can be exposed? We mentioned the left thoraco-phenolaparotomy approach, and we mentioned the retro peritoneal exposure, and now through the transperitoneal exposure or through the laparotomy, we can also explore the origin of this vessel by making an incision in the peritoneum lateral to the colon and spleen. Lateral to the colon and spleen. And then by displacement of the colon, the spleen, and the liver to the right side, we can find the origin of the superior mesenteric artery together with the celiac axis and the left renal artery and the left renal vein. So that's the origin of the superior mesenteric artery. Well, sometimes we need to explore the superior mesenteric artery or a longer segment of the superior mesenteric artery, not just its origin. So what we have to do, we have to displace the small bowel to the right side, and at the free edge of the mesentery, we can feel the superior mesenteric artery accompanied by the superior mesenteric vein. And by doing an incision in the peritoneum here, we can isolate the superior mesenteric artery. We have to be quick because we have only 10 minutes remaining for our presentation. Just in case the time is over, I think we can re-enter or rejoin the meeting again by using the same ID. Okay. Exposure of the renal arteries. Renal arteries are exposed using a transverse or vertical abdominal incisions. And then, as I told you, after displacing the bowel to the right side, we can see the left renal vein. The left renal vein can be encircled by a sling and retracted inferiorly, and this will allow us to expose the left renal artery. Well, what about the right renal artery? The right renal artery is exposed by incising the peritoneum lateral to the duodenal loop and by displacing the duodenum medially, the so-called coherization. So if you look at this picture here, you can see the left renal artery arising from the aorta. Okay. Exposure of the splenic artery. The splenic artery is exposed by dividing the greater omentum along the outer border of the stomach and displacing the stomach medially. The artery will be seen running along the upper border of the pancreas. That is the exposure of the splenic artery. What about the splenic vein? The splenic vein lies behind the pancreas. Therefore, it is best exposed by incising the peritoneum lateral to the spleen and then displacing the spleen and the pancreas medially. Okay, and then the vein will be found at the back of the pancreas. The vein, splenic vein, will be found at the back of the pancreas. Exposure of the IVC is done by opening the peritoneum lateral to the duodenum and lateral to the ascending colon, and by displacing these structures medially. This will give us a very good exposure of the IVC below the liver. Okay? And this technique is called right medial visceral rotation. Mobilization of the right colon and a Kocher maneuver will expose the entire IVC except the retrohepatic portion. It's technically simple, and the kidney can be left in situ or mobilized with the remaining viscera. So that is the entire IVC. The entire IVC has been isolated. Just the opposite to right medial visceral rotation, we have a technique called left medial visceral rotation, which can be used for exposure of the abdominal aorta. Again, an incision is made lateral to the colon, and the process is completed until the aorta is isolated. This technique and left medial visceral rotation is more technically difficult and more time consuming in comparison with the right medial visceral rotation. Sometimes in trauma, we need to expose the bifurcation of the IVC, okay? And for that purpose, we need to divide the right common iliac artery. And after finishing the repair of the injured venous segment, the artery should be reanastomosed. Again, in trauma, we have a technique called pelvic vascular isolation. When we have bleeding from a major vein like the IVC or the iliac vein, and the field is filled with blood, it's very important to be patient. We suck the blood, we do a gentle dissection with the aid of the assistant, and we can put vascular clamps, and we move the vascular clamps gradually until we reach the area of injury. Okay? So that's called pelvic vascular isolation. Exposure of the iliac artery. For that purpose, we do an oblique incision in the iliac fossa, and after that, to expose the iliac artery and vein, the muscles are divided and the peritoneum mobilized medially, taking care to avoid the ureter, which crosses the bifurcation of the common iliac artery. And then, if we want to isolate the internal iliac artery, we have to do a sharp dissection and put a sling around the common iliac artery and around the external artery, and by traction on these this length, we can isolate the origin of the internal iliac artery. Okay, so by now, we have discussed the exposure of the important vessels in the thoracic and abdominal cavities, and I think exposure of the blood vessels in the abdomen may be more difficult than exposure of blood vessels in the chest and also in any part of the body because of the presence of many viscera and because of the location of the abdominal vessels, the aorta and its branches, the IVC, etc. All of them actually are located behind the peritoneum. So we have to reach these vessels either retroperitoneally or transperitoneally, but we should have a very good anatomical knowledge of the location of these vessels so that we isolate them in the shortest time and without